Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This JCO podcast provides observations and commentary on the JCO article, Prospective Evaluation of Magnetic Resonance Imaging MRI and Positron Emission Tomography Computed Tomography PET-CT with fluorodeoxyglucose, a diagnosis and before maintenance therapy in symptomatic patients with multiple myeloma, included in the IFM and Dana-Farber Cancer Institute 2009 trial, results of the imaging study by Moro et al. My name is Jesus San Miguel. I am Professor of Hematology and Director of Clinical and Translational Medicine at the University of Navarra in Pamplona, Spain. My oncologic specialty is hematology, and I am particularly involved in multiple myeloma. The outcome of multiple myeloma patients has significantly improved during the past 15 years, mainly due to the use of novel drugs such as proteasome inhibitors and immunomodulatory agents, and more recently, monoclonal antibodies. Progress has also been made in understanding disease biology, diagnostic criteria, and patient stratification. However, until very recently, response criteria and clinical endpoints have largely remained the same. Retrospective analysis among transplant-eligible and non-transplant patients have shown a link between depth of response and outcome, with patients achieving complete response having longer survival. However, the clinical relevance of complete response and its utility as an endpoint in multiple myeloma have been questioned, probably because it is based on low sensitivity techniques such as morphology and immunofixation. Therefore, it is crucial to improve response assessment in multiple myeloma by incorporating more sensitive methods for detecting minimal residual disease. So far, most efforts for minimal residual disease assessment have focused on the bone marrow compartment using immunophenotyping by multiparametric flow cytometry or molecular analysis by ASO-PCR or next-generation sequencing. These techniques can reach a sensitivity level of 10 to the minus 6, meaning detection of one tumor cell among 1 million bone marrow cells. Recent studies using these methods are showing that minimal residual disease status is one of the most relevant independent prognostic factors in multiple myeloma, and that persistence of minimal residual disease consistently predict for inferior progression-free survival and overall survival. In fact, in a large study that included over 600 patients published on May 2017 in Journal of Clinical Oncology, the Spanish group have demonstrated that minimal residual disease negative status surpasses the prognostic value of complete response achievement for progression-free survival and overall survival across the disease spectrum and regardless of type of treatment or patient risk group. Accordingly, minimal residual disease negativity should be considered as one of the most relevant endpoints for multiple myeloma. However, it should be noted that due to the patchy pattern of myeloma bone marrow infiltration, a negative minimal residual disease result may not be indicative of disease eradication, but may instead be the result of a non-representative bone marrow sample. Therefore, methods to evaluate minimal residual disease outside the bone marrow are also needed in multiple myeloma. Sensitive imaging techniques to detect bone lesions and bone involvement at diagnosis have recently been incorporated into the new myeloma diagnostic criteria. These include whole body computed tomography, magnetic resonance imaging, and positron emission tomography computed tomography using fluorodeoxyglucose. In addition, both MRI and particularly PET-CT have shown to be of prognostic value, both at diagnosis and for monitoring treatment efficacy. Thus, the Arkansas group has shown in a large series of patients treated with frontline autologous stem cell transplantation that the number of focal lesions evaluated by MRI at baseline was a strong predictor for event-free survival, and that the number of focal lesions detected at baseline by PET-CT also retain a prognostic value for overall survival. Moreover, they found that the suppression of PET metabolic activity after transplant was also a strong predictor for overall survival. These data have been reproduced by Samani et al. In patients treated with tandem autologous stem cell transplantation, showing that complete fluorodeoxyglucose suppression at PET-CT was associated with longer progression-free survival and overall survival. However, a prospective comparison between MRI and PET-CT in patients receiving optimized induction therapies with a proteasome inhibitor and immunomodulatory drugs was still lacking. In the prospective study conducted by the French and Dana-Farber group, all patients received 3 induction cycles of lenalidomide, bortezomib, and dexamethasone, RVD, and then were randomized to receive either 5 additional RVD cycles or autologous stem cell transplant plus 2 RVD cycles, followed by lenalidomide maintenance in both arms. In the context of this clinical trial, a subgroup of 134 patients was enrolled into the prospective ancillary imaging study, which is the subject of this podcast. The preliminary endpoint of the imaging study was to compare MRI of the spine and pelvis versus whole-body PET-CT regarding the number of bone lesions at diagnosis. Secondary endpoints were to evaluate the prognostic impact of MRI versus PET-CT at diagnosis after 3 cycles of induction therapy with lenalidomide, bortezomib, and dexamethasone, RVD, and before maintenance therapy. Fluorodeoxyglucose PET-CT and MRI images were acquired in each center according to predefined protocols, and after anonymization, images were centralized review by 2 experienced readers. Response to treatment and disease progressions were assessed according to the International Uniform Response Criteria. Bone marrow samples were collected before maintenance for minimal residual disease measurement by 7-color flow cytometry, which has a sensitivity level of 10 to the minus 4. At diagnosis, MRI of the spine and pelvis and whole body PET-CT were equally effective in detecting bone lesions in patients with symptomatic multiple myeloma diagnosis, being positive in the majority of patients, 94.7% and 91% respectively. Following the 3 induction treatment cycles, the rate of normalization of MRI was very low, 3%, and increased to only 11% of patients before maintenance. This low rate of normalization was neither predictive of progression-free survival nor overall survival, indicating that the lack of effectiveness of MRI during follow-up to assess the prognosis of myeloma patients. Novel MRI techniques such as diffusion-weighted imaging MRI or dynamic contrast-enhanced MRI must be investigated in order to assess if they had better capacity to define response. By contrast, PET-CT became negative following the 3 induction cycles in 32% of the patients, and this was associated with a significant improvement in progression-free survival. Specifically, the 30 months progression-free survival for this group was 79%, compared to only 55% in cases of PET positivity, but significant differences have not yet been observed in overall survival. Before maintenance, PET-CT normalization was observed in 62% of the patients, and this was associated with significantly better outcome for both progression-free survival and overall survival, with a 3-year overall survival rate of 94.6% versus 69.9% for patients who did not normalize PET-CT before maintenance. On univariate analysis, 3 factors were significantly associated with a better progression-free: normalization of PET-CT after the 3 RVD induction cycles, normalization of PET-CT pre-maintenance, and to achieve VGPR or better after induction. As far as overall survival is concerned, normalization of PET-CT before maintenance was the only parameter associated with a significant superior outcome. It should be noted that these results apply to both Arm A, RVD for 8 cycles, and Arm B, RVD plus frontline autologous stem cell transplantation. In spite of these outstanding findings, it should be noted that one of the major limitations of PET-CT is the lack of standardization, and consensus guidelines need to be urgently implemented, similar to what had been done for lymphoma. Interestingly, 86 out of the 134 patients were evaluated for both PET-CT and minimal residual disease assessed by 7-color flow cytometry before maintenance. The concordance rate of these 2 tests were low, indicating that these 2 tools are complementary in predicting the outcome of patients. In fact, progression-free survival was significantly higher for the group of patients with both a negative PET-CT and a negative minimal residual disease before maintenance. In particular, the 3-year progression-free survival was 89.6% for this group, compared to 54.5% for patients with either PET positivity and or minimal residual disease positivity before maintenance. Overall, these results confirm the previous observation of the Arkansas and Bologna group and would support the implementation of PET-CT for the routine monitoring of treatment efficacy in multiple myeloma. Moreover, as suggested in the new response criteria, functional metabolic imaging minimal residual disease negativity should become a clinical endpoint complementary to bone marrow minimal residual disease negativity, assessed by next-generation flow or sequencing as surrogate markers for long-term survival or even cure in multiple myeloma. Minimal residual disease techniques will also contribute to avoid both under and over treatment, particularly when evaluating consolidation or maintenance therapies. In addition, minimal residual disease evaluation will be probably complemented with a simultaneous analysis of the genetic characteristics of the residual cells. For instance, is not the same if they harbor a 17p deletion or normal cytogenetics, as well as the immunoprofiling of the bone marrow cells, since a good immune surveillance may help to control the minimal residual disease clone. This concludes this GCO podcast. Thank you for listening.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.